think our numbers have stabilized. We're somewhere around 150 participants, which is excellent, and welcome everyone. Delighted you can all join us for this ESID Grand Round on chronic viral infection. Now, I admit to having a significant bias here, because this is obviously my area of real interest. I say obviously. Most of you don't know who I am. I'm David Lowe. I'm an immunologist in London at the Royal Free and at University College London. And my background's in infectious diseases. So I trained initially in ID and then made a lateral step to immunology. And my interests have been in many things, in many infections, in immune deficiency, but I'm fascinated by chronic infection, especially chronic viral infection. We were going to have 3 talks today. I'm afraid that one of the speakers, Professor Judy Brewer, is unwell and is unable to make it today, but we've got 2 excellent talks lined up. And I'm really excited about these because, as I'm sure you know, chronic viral infection is a really difficult problem in people with immune deficiency. We still don't really understand enough about it. We don't know what to do with it. We don't know how to prevent it, to treat it, etc. And the conditions are rare. The underlying conditions are rare, and then the infections themselves are rare within rare cohorts. And so I think it's one of those things where we really need to pool our resources and pool our expertise. And I think we can certainly say today that we've got the absolute world experts in these areas to talk to us, which is really exciting. So I'm going to enjoy today. I hope you will do as well. And we're going to start with Professor Kate Sullivan, who is, many of you will know her, who is the chief of the Division of Allergy and Immunology, and is definitely the world expert on rubella-associated granulomas, so skin granulomas associated with rubella virus. And Kate, I'm really looking forward to this because, as I've mentioned to you, we have a patient recently diagnosed with this. We don't really know what to do with her, and I'm hoping you can give us some answers. So over to you. Thanks very much.
Felt a bit of pressure there. Let me just get my slides set up here. And I'll start off by saying it's an honor to be here. I always enjoy the ESID webinars as well. So I'm happy to be a presenter, and I'm a proud ESID member, even though I'm from North America. Not even really saying US these days, I'm just saying North America. Probably you can appreciate why. So I'm going to talk about rubella today. I do not have any disclosures. And I'm going to start with this schema. And you probably think about this all the time. You might not draw it this way, but you probably have in your head something like this, meaning there are pathogens where everything that causes disease is related to the pathogen. And the example I usually give is rabies. Rabies doesn't care if your immune system is perfect or deeply flawed. The virus is going to crawl up the neuronal axons and infect the brain, and it is almost always fatal. On the other side are diseases that are almost entirely immunologic as we understand them today. Is there an influence from the microbiome? Maybe, but as best as we can tell, they are not pathogen-driven. These would be things like lupus, familial Mediterranean fever as an autoinflammatory disease. It's really just the immune system causing the pathology. So neither of these are problems on the clinical realm because we largely know what to do about that. I think the messy part in the middle is where we often struggle as clinicians. So the 2 examples that I've given are Epstein-Barr virus, hemophagocytic lymphohistiocytosis, and varicella vasculitis. For both of those, we would treat both the pathogen and we would treat the inflammation. And you know as well as I do, there's a variety of strategies for doing that. But in recognition that both the pathogen and the immune system are causing harm, we would typically treat both. But you can imagine examples that are in more gray zones. We don't usually immune modulate for leishmania, but maybe we should. You take my point. As you start thinking about the less obvious combinations, it becomes much harder to decide when should we treat the pathogen, when should we treat the immune system. And that is the construct I want you to hold on to as I talk about rubella today. Now, rubella is a human pathogen. And so at various points when I give talks on rubella, people will say things like, well, just, put it in a mouse. Well, you actually can't. You can't even put it in a Hue skid mouse. It does not support sufficient replication, and there may well be a message there, but it does mean that we are a little limited in terms of the questions we can ask to better understand what's going on. So let me tell you how I got involved in this, because it's not very different than how David Lowe got involved in this, and it probably won't be very different than how some of you get involved. So I had a case in 1996. So this is a long time ago. And in 1996, what I knew is I had a little girl with cartilage hair hypoplasia and terrible, I'll show you a picture in a minute, terrible granulomatous lesions on her legs that we all presumed were pyoderma gangrenosum. That little girl died about 10 years later of lymphoma, but I was very close with the family. I stayed in touch. And so she was in my mind in 2014 when I got a call from Stanley Plotkin. Now, if you don't know the name, he's the inventor of the rubella vaccine. He did the attenuation that led to the particular strain that's in the MMR right now. And he called me up and said, I heard at Institut Pasteur that they found rubella in immune deficient patients with granulomatous skin lesions. I'm really worried. And would you look at your patients? And that's what started me on this 10-year journey. So this is the little girl I told you about. This is her worst lesion. She's about 5 years old in this picture. This has recently been debrided, but it had purulent discharge all the time. It was wrapped in bandages. These are the rest of her lesions. They didn't all ulcerate, but some did. You can see they're very pleomorphic. And I was talking to David Lowe at the beginning. There seems to be a predilection for the extremities, for the hands, the feet, and in particular, the legs. And what you can't see in this little girl, you can see a little bit of her arm and her legs, but her torso was spared and her face was largely spared. That's not 100% the case, but I would say generally we find it on the extremities more than anywhere else. Now, she had been biopsied multiple times before I ever met her, and she had granulomas, which is why we sort of thought this was pyoderma. If you're not familiar with granulomas, let me just orient you a little bit. In the center, these are activated macrophages. Pathologists call them epithelioid cells, but they're really just activated macrophages. And then there's some small blue cells that are sort of forming a ring around the central area, and those are T cells. At least from tuberculosis, they are not all antigen responsive. So if you can see my little laser pointer, this whole ring of small blue cells is lymphocytes and almost all T cells. So because Stanley Plotkin said, I want you to look at your patients, the middle panel is my first patient. Still today, this is how we screen samples. You will hear more about what we do in a minute, but this is how we screen samples. So I work with the CDC, I work with Ludmila Paralegina, and they have a very highly purified antibody that they use for rubella capsid detection. That's what's shown in red in this immunofluorescence. The blue is just a nuclear stain called DAPI. It just helps you orient on the slide. So you can see my patient had a lot of rubella. And then on the left is a patient from Finland that Timo Hautala sent in. And also we found rubella there. Over on the right is some rubella that has been shed into the overlying keratinocytes. Usually we see it in macrophages, and more on that in a minute. Because I love macrophages above everything else, I know not many people talk about their favorite cell. I love macrophages. And so we wanted to understand what was going on with the macrophages. So we did some special stains. And I will just share with you that we find it in what we would call M2 macrophages. So these are typically the macrophages you see in tumors associated with parasites. They are healing macrophages. They're very focused on healing, whereas CD163 macrophages are more about killing. You can appreciate the overlay of the red rubella with the green CD206. We find it in M2 macrophages. Now, quite reasonable question to ask is who gets this condition? And so 70% of those with inborn errors of immunity and chronic skin granulomas are rubella virus positive. Not 100%, but the majority of samples that we get from skin are positive. And if you ask what are the types of immune deficiencies. This is from a published paper, and you can see it's largely T-cell disorders. So Stefan L. has a nice paper looking at HLH conditions and chronic rubella. It's largely, but not exclusively, T-cell disorders. And you can see over on the right, I've listed some comorbid viruses, and you get the sense that these are pretty immune deficient patients, right? If they're getting Mycobacterium, they definitely don't have a fully functioning immune system. Well, again, what's going on with these people? A couple things to notice about age of onset. So I've slightly ordered these with the more severe T-cell defects at the bottom. And at the top, we have a small number of patients where we cannot find an immune deficiency and they still have rubella. And what I hope you can take away is that there's a little bit of a gradient. So the more T-cell compromised you are, the earlier onset we see. But among these folks up here that are presenting in their 60s, these are largely people without immune deficiency. I'll tell you more about this gentleman with common variable in a minute. And I just had a woman who already had chronic rubella, and she has since gone on to develop common variable. Well, what I want you to take away is if these people were vaccinated as a 1-year-old or a 2-year-old and were totally well for 60 years, and then develop this chronic skin inflammation, it implies that rubella has entered a reservoir. That was not known to be the case about rubella, and you might believe that our immune system gets rid of all viruses, but that is actually not the case. And we know there are herpes viruses that enter latency, adenovirus enters reservoirs. There are lots of examples of viruses that once we are infected, those viruses persist. It was not known to be the case for rubella, but it does seem to be the case for rubella. Now, this is a gentleman who I knew and loved. He died just last year. He presented with these lesions. He also had quite severe lesions on his legs that I'm not showing you. And they came out after he developed rheumatoid arthritis. You can see the rheumatoid nodules on his knuckles. And he had common variable that developed right about the same time. So he had rheumatoid arthritis, and then about a year later, these came out, and then he was found to have common variable. What's interesting about this gentleman is he's old enough that he was infected with wild type rubella, not vaccine strain. Almost always when we sequence the virus, we get back vaccine strain. But he was alive in 1964. He was presumably infected with the circulating strain in the US. That was the last big epidemic we had in the US. And he carried it asymptomatically until he was in his 60s. And then these lesions emerged. So 2 points to make. I think this does make the point that there's likely a reservoir. And it makes the point that it's not just the vaccine. A point I always like to make. Well, where don't we find it? Could rubella just be a passenger? We're always worried about that. So we don't find it in granuloma annulare. We don't find it in nasopharyngeal swabs. We don't find it in granulomas that are from non-immune deficient patients, in internal granulomas. And we looked at patients with sarcoid and we didn't find it. So I don't think it's a passenger, but the role that it's playing is not 100% clear. What's interesting is there have not been any reported cases with HIV. You would think it would show up there. And we haven't seen it post bone marrow transplant as a clinical disease, but we can recover virus. And I'll tell you more about that in a minute. Now, I showed you a picture of a granuloma, and I said we mostly find it inside the M2 macrophages. And this is an example on the left of that, but we do also find it in necrotic granulomas in neutrophils, and sometimes we find it just in neutrophils. This is what we would call an N-type granuloma, meaning the virus is in the neutrophils. Here we're using myeloperoxidase as our neutrophil marker. And if I just summarize our cell type specificity, in the cutaneous granulomas, it's largely in macrophages, but not exclusively. We do see it in neutrophils. But when we find it in liver, in brain, in lung, in a lymph node, it's not usually in macrophages. It can be a little bit of a mixed picture, but we're more likely to find it in neutrophils. I think that's really interesting. I'm not sure what to make of it. So we asked our questions like any of you would. What the heck is going on here? I don't think of viruses as causing granulomas. What's going on? So we first hypothesized that the virus had mutated, and that's what was doing it. We do not see conserved mutations. So in this figure, every vertical line is a mutation from the vaccine strain. You can see there's not really conserved mutations. And we actually see in the same patient in different locations, different sequences. You can see that at the bottom. The bottom is a nasopharyngeal sample, and next to last is the same patient and a granuloma. There's some overlap of the mutations, but not a lot. Now, interestingly, we had this other hypothesis that maybe there was something difficult about rubella for T cells to latch onto. And this is work done by Versen Nambuzi in Malawi, and he did a bioinformatic approach. And you can see rubella partly because it's quite small, the genome is only 10 kilobases. It actually has very few MHC class 1 epitopes, much fewer than measles and mumps. So is that a part of why this is such a difficult virus to eradicate? I don't know, but I can't help but wonder if it somehow compromises T cell clearance. Well, as you know, I am a macrophage lover. So is there something going on with the macrophages here? So it turns out that inflammation actually enhances rubella replication. So if you look at the dark blue bars here, I've got just rubella infected monocytes. Here they're treated with LPS. You get out about twice as much virus. We don't see the same thing with poly-IC, and we don't see the same thing with influenza. And the other point to make here is when we treat the cells with a JAK inhibitor, we get more virus. And this is work done by Shrusti Patel. So there are some qualities of the macrophages that modify viral replication. So the macrophages, I would say, are facilitators in some way. I didn't talk about the tissue tropism, but if we recover virus from skin, it always grows best in skin. If we recover virus from lung, it grows best in lung. If we recover virus from brain, it always grows best in brain. So there are some viral attributes, but we think the macrophages mold the behavior of the virus. Well, what about T cells? If you're thinking about chronic viruses, you're definitely going to think about T cells. Is there something wrong with the T cells? Most of the patients had T cell immune deficiencies. So we thought this as well. So this is a marker of T cell exhaustion. This is now in a skin biopsy. And so the CD8 T cells do have activated caspase-3. So we said, this seems a lot like exhaustion. And we pursued it. Sorry, I took out a slide. We did pursue it. We actually don't see peripheral blood evidence of exhaustion in every patient. We see it in about half. So the role of exhaustion, I think there is an important role, but I'm hard pressed to say it's 100% the explanation. So let me just summarize what I've told you so far. The macrophage characteristics modulate rubella replication. The T cells may have an element of exhaustion. And so in this schema, I would put rubella in the middle. Clearly, there's an aspect of the immune system that facilitates the clinical presentation. But I do think there are some aspects of the virus that are important for this. And I'll just end with a couple of quick thoughts. Does everyone carry rubella? If we say there's a reservoir, is it in everyone? Why does it escape control? We don't know the answer to that. And importantly, can we help the patients? So does everyone carry rubella? We find it in about 3/4 of the patients. So these are bone marrow samples. This is a Western blot, and you can see 4 out of the 6 are positive. That's about our going rate, somewhere in the 50 to 60% range. If we look by PCR, you would think that would be more sensitive. We actually find it less by PCR than by Western blot, and I can answer questions about why that might be. But again, we're in the 30 to 40% range. So maybe not everybody carries this virus. This is a graft versus host metagenomic sequencing, and they found rubella in graft versus host after bone marrow transplant. So we're not the only, often I get asked, could it be a PCR artifact? We're not the only ones finding it. And then David asked me, can it be treated? So this is a summary. I know you can't read it. The font is tiny. This is a summary of all of the studies. I'm just going to tell you the punchline. Nitazoxanide works in about 1/3 to half. Doesn't always clear it, but you often will see some improvement. We've also treated patients with topical steroids and systemic steroids. The two gentlemen that got systemic steroids, their lesions cleared. We were thrilled. And then they died of something else. Now, these were older gentlemen with a lot of comorbidities. So I'm not willing to say the steroids did them in, but we are cautious in our use of steroids. Oh, sorry. And the biggest point of all is that at least for children, transplant is curative. It's not like it persists. It's like HPV. When you do a bone marrow transplant, it goes away. It's really quite magical. So this is our model. I'll just end with this. We think either some kind of exposure, either vaccination or wild type. There's initially immune control that chases it into a reservoir. We have worked really hard to identify the reservoir. I don't know what it is. Then there's time and loss of control. We know that myeloid cells carry it to the skin, and somehow, in a way we don't fully understand, that facilitates the development of granulomas. So there are no FDA-approved antiviral treatments for rubella. We are working on nucleoside analogs, and we have identified 4 or 5 that work in vitro, but they are not FDA-approved. They're not available for purchase. Can we treat the exhaustion? So Morna Dorsey at UCSF treated one of her patients with pembrolizumab, and he did clear his lesions. They came back when she stopped pembrolizumab, she restarted pembrolizumab, and they cleared again. So I do think there could be a strategy there. So I want to leave you with this thought. Is rubella the only virus that's causing granulomas or chronic inflammation? I trained as a rheumatologist. I was surprised by finding rubella, and I can't help but think there are other pathogens doing the same thing. So I'm going to stop. I've tried to mention people. This is Ludmila Periligina, who taught me everything about rubella. I introduced Stanley Plotkin. This is my lab at the bottom. And so I will stop there.
Fantastic. Thanks so much, Kate. That was really fascinating. And as I anticipated, I really enjoyed it. Just as a point to the audience, which is now at nearly 250 people, if you've got any questions, please do put them in the Q&A. We can try and answer some by typing in the answers if it's easy. Otherwise, I can obviously bring them to ask the speakers. A couple of questions I had, first of all, Kate, if that's okay. The older patient with CVID and rheumatoid, did he receive immune suppression for the rheumatoid? So was there any sort of trigger then? I wonder, because when we look at our chronic norovirus patients, actually quite a lot of them, when you look back to their history, there is iatrogenic immune suppression on top of the IEI, which is, for me, looking at adults, usually CVID.
He was treated with methotrexate, which I don't really think of as strongly immune suppressive, but he did get methotrexate before his lesions came out.
Okay, yeah, interesting. And interesting the point about steroids as well, and how there may be a double-edged sword there in terms of, and we see that again with other chronic viral infections as well, that there's always an inflammatory component you can control, but actually, are you doing the right thing in the long term? The other question I had, and you alluded to it, was about viral heterogeneity. And you mentioned when you put up the slide about mutations that even within one patient, you can see quite a lot of heterogeneity. Again, that's something we see with other chronic viral infections as well. Do you think that might make treatment harder? I mean, by the time we're starting, we're already facing this sort of pretty diverse group of viruses rather than a single genotype.
I, of course, don't have a perfect answer to that question, but I would note that by their very nature, the non-structural proteins are much less tolerant of variation than the structural proteins. I didn't make a point of it, but there's about 3 times more mutations in the structural proteins than the non-structural proteins. So I think it at least limits that mechanism of viral escape, but until we start treating, I think it's going to be hard to know.
Yeah, okay. Thank you. There's a question in the Q&A asking whether you think pegylated interferon might work as a treatment.
So interesting question. So in vitro, various interferons have been used in vitro and are not effective at suppressing replication. When we used the JAK inhibitor and we saw enhanced viral replication, it made us rethink that. As you know, there are a lot of type 1 interferons. Maybe there's a particular type 1 interferon that we didn't try. And so I would say the jury's out on that.
Okay, interesting. And of course, there's a theory that nitazoxanide works in part by enhancing type 1 interferon immunity. And we don't really know how it works against viruses, right? It's not what it was developed for. There's a question, someone else is choosing their favorite cell. You mentioned my favorite cell, which is a neutrophil, so I'm happy. But someone else has mentioned NK cells, which I've got to assume is their favorite cell. Any role for NK cells that you found? That's Ray and Goda.
So NK lover, I'm talking to you. I don't know the answer to that. I don't know what role NK cells play in rubella.
Okay. Gisela Seminario has asked about XLA. So two brothers with XLA who has got, well, it looks like various chronic infections. I'm not sure that's all rubella. I wonder if maybe we should hold this one for after Benedict's talk as well, because I think Benedict might touch on livers, etc., if that's okay. All right, this is an interesting question from Vignesh Pandyarajan. Do you think skin granulomas in CGD could be rubella derived?
So we have looked, we have a pretty big CGD population here. We have found it a couple times at super low levels, and by super low levels, I mean like 1 out of 10,000 cells. So we don't know exactly what to make of that. Interestingly, we've seen it both in macrophages and neutrophils in CGD, but at such low levels. I'm not sure in those circumstances that it's not a passenger.
Yeah. Which then raises interesting questions, of course, that, if you find it as a passenger in other situations, is it definitely causative in the other IEIs? I mean, I think, to my mind, the fact that you get response to treatments that target the virus, like nitazoxanide, I mean, that's the best proof, right, overall. There's another question about CGD. What successful treatment has been used apart from transplant? Well, I think you touched on that, and nitazoxanide probably, I think, I don't want to speak for you, but seemed to be the only other treatment that's got some sort of efficacy data. I mean, there is a theory that some of the other broad spectrum RDRP inhibitors might help, given that it's an RNA virus. But as you said, you've screened lots of things in vitro, and there's not many that have come up. Is that fair to say?
Yes, we're excited about the potential of nucleoside analogs. We think we've identified a conserved structure, but going from that observation to actually getting it into patients seems like quite a big journey. But nevertheless, I think it's worth spending time and energy on.
Yeah, excellent. Okay, a couple of final questions. Carsten has asked regarding outcome/risk in transplant. Is there a difference in granulomas caused by wild-type virus in comparison to vaccine strain virus?
Karsten, we only have one example of the wild-type virus that we've recovered through sequencing, so I think we don't have enough sample size to say.
Okay. And I'm just going to do this one, which I think is interesting as well, which is third-party rubella-specific lymphocytes. I guess we're getting lots of sort of off-the-shelf interesting products now. Yeah. Any role for those?
I think there could be. We've had a number of conversations with groups that are pursuing it. I think the activation energy is maybe pretty large to develop that de novo, but why would not it work? And so I think it's quite reasonable to think about it.
Yeah, no, I agree with that. I think that could be really interesting. Okay, if I had to really push you, last thing, where do you think the reservoir might be? The reservoir, I mean, it's fascinating, right? That you've got people, I mean, those immunocompetent people, or apparently immunocompetent, is still there decades later.
Yep. So I periodically, I am rubella virus positive in both my neutrophils and my monocytes in the blood. I mean, you have to purify it, but you can find it. So I think it is in a reservoir in many people. We did the sort of usual approach where we took bone marrow. Since we find it primarily in myeloid cells, we said, let's look at myeloid precursors. We looked at CD34 stem cell, so we did sort of the obvious way, and we couldn't track it to any one cell type. So now we're going to think about stromal. Anyway, it's embarrassing that we worked on it this long and we don't know the reservoir cell.
it's fascinating. There you go. Keeps you in a job. And keeps all of us fascinated. Thank you so much. That was absolutely brilliant. Thank you. Okay, and I'm delighted now to move on to our next talk, which is Bénédicte Nevin. Bénédicte probably doesn't need much introduction to most of the audience here. So she's a professor at the Necker in Paris, working in immunology, hematology, does a lot of work on transplant, but of course intrigued many of us with work on HE virus in livers in the relatively recent past. And she's going to give us, I think, a slightly wider talk today about enteric viral infections, and obviously with a focus on chronic viral infection. So Bénédicte, thanks so much. I'm looking forward to it.
Thank you very much, David, for this introduction. And indeed, it's really a great pleasure to join you today to talk about enteric virus infection in primary immune deficiency. But of course, I will focus on my favorite virus, which is IK among these enteric viruses. Short introduction about these enteric viruses. You know that these viruses primarily infect cells of the small gastrointestinal tract, is responsible for acute gastroenteritis for most of these viruses, but not only. We know that some of these viruses can have other tropism. It's usually transmitted by fecal oral routes, and most of these viruses are non-enveloped and are mostly RNA viruses. There are 5 most important families, and I will focus on these 5 most important families. The first family is the Picornaviridae virus, which is a very small virus with different genus in humans. The very, very large enterovirus family responsible for broad diseases, not only gastrointestinal infection, but also and foot mouth disease. And we know that some of these viruses may also have a neurotropism, and I will shortly come back on this. Pericovirus are very close to enterovirus and responsible for very close clinical manifestation. And Cobuvirus, which is the genus for IK virus, probably responsible for acute gastroenteritis in immunocompetent humans. But even this, there are some discussion about the pathogenicity of IK in immunocompetent humans. Rotavirus is a very well-known gastroenteric viruses. Norovirus and sapovirus also very well-known. Astrovirus and adenovirus are also other well-known enteric viruses that I will not cover today. So I will start my talk with a short case discussion. It's a small boy that who comes from Gaza and who was transferred to Necker a few months ago. He was diagnosed with a severe combined immunodeficiency, disseminated BCG related to RAC2 deficiency. It was in Gaza in 2019, and he received a haploidentical transplant from the father in Jordania after receiving reduced intensity conditioning with Flumel and ATG with PTCY. He had a good donor chimerism on T cells, but unfortunately on myeloid cells, he progressively displayed a drop of the donor myeloid cells from 40 to 3%, and he was not able to recover B cells, and he needed to be on immunoglobulin replacement therapy. 12 months after transplantation, because of pancytopenia, he had the bone marrow aspirates with a positive enterovirus PCR in the peripheral blood and in the bone marrow, but no real symptoms related to this enterovirus. And 2 years later, he presented several episodes of seizures. We don't really know if it was always associated with fever. We don't really have many information about this period because the child was in Gaza. and he was also diagnosed at that time with deafness and speech delay. And 2 years after these episodes, he was transferred in France because of the problem in Gaza, and because he also presented acute hepatitis at that time. When he arrived to us, it was quite lymphopenic with 300 CD3, very low CD4, CD8 T cells, low naive T cells, no B cells, low IgG level despite treatment with immunoglobulin, and he had no IgA, no IgM, though, so clearly very poor B-cell immune reconstitution or absence of B-cell reconstitution, and poor T-cells reconstitution. The hepatitis recover in few months. We found a sapovirus in the stools, and when you get rid of the sapovirus, the liver enzyme went back to normal. And we were in face of a child with a poor growth status, deafness, some developmental delay, and speech delay. So we thought that maybe this child coming from a consanguineous family may have a second genetic disease. We did whole genome sequencing, and we didn't find any clear explanation. In the screening, when you arrived, we did different PCR in the blood, and again, the enterovirus PCR was positive. It presented relapse of seizures in front of us. We explored the CSF. We found an increased cellularity, an increased protein in the CSF, and a positive enterovirus PCR in the CSF. And we asked for the serotype of the enterovirus that was found to be an ecovirus 14. This ecovirus 14 is a rare serotype with low level of circulation, which may explain the failure to improve the viral and clinical status of the patient with high dose IVIG. And we also try Pocapavir, which is a new antiviral drug, but we were not able to improve the clinical and virological situation of this child. That show also at the MRI some hyper signals of the white matter. So we are now considering a second transplantation to this child, because we think that his clinical situation is mainly related to chronic enterovirus infection in a child with absence of B-cell reconstitution and poor T-cells reconstitution. We know that the enterovirus is a very large group of virus with more than 100 serotypes able to infect humans. There are different subtypes of enterovirus, the enterovirus by itself, Coxsackie virus, ecovirus, and of course poliovirus, which is the prototype of enterovirus responsible for poliomyelitis. We know that this enterovirus is a specific threat for a patient with immunodeficiency, and specifically for patients with defect of antibody production that may have a high tropism for CNS and being responsible for meningoencephalitis and myelitis, with a very chronic course among years and years, with a wide range of symptoms, with paresis or paralysis, epilepsy, developmental regression, cognitive impairment, deafness, ataxia, dysarthria. So many different types of neurological symptoms. Patient may also have dermatomyositis-like disease, arthritis, or hepatitis. So it's really a concern for patients with B-cell defects that can be diagnosed with the CSF examination. Sometimes the brain biopsy are more cost effectiveness than the CSF. And when we look to the serotype responsible for these disease, ecovirus are the most frequent, and in particularly the ecovirus 11 among others, and the Coxsackie viruses A16 or B3 are also frequently identified. It's not only a threat for children, it's also a threat for adults across all ages, and mostly for patients with B-cell deficiencies, XLA and autosomal recessive agammaglobulinemia, CVID, SCID, or combined immune deficiency, which are mainly suffering from vaccinal poliovirus infection. And patients treated with B-cell depleting therapies can also be affected with these chronic antiviral infection. Unfortunately, we don't really have a good pharmaceutical treatment for these chronic infection. We all tried pleconazole when it was available, with more or less successful cases. We all use high-dose IVIG, which can be helpful when the antivirus is a frequent serotype with high level of immunoglobulin in the industrial preparation. Intrathecal immunoglobulin can be an option, but not so easy because it needs Ommaya, and it can be a risk for infection. And there are new capsid protein inhibitors that are entering the market, and in particular Pocapavir, but with a variable success. So it's a severe disease that can lead the patient to transplantation to recover full B-cell function and full immunity to these antiviruses. It was a short introduction to this problematic of antiviruses. I would like to introduce these second cases, XLA patient diagnosed at birth because of family history. And he was put on regular immunoglobulin replacement therapy with a good residual level. And until the age of 12, he was considered as healthy without any infectious problems. At the age of 12, he was referred to us for chronic fatigue, some recurrent fever. The fatigue was responsible for decreased school performance, and he also had the recurrent episodes of epistaxis. He had no diarrhea, no respiratory symptoms, but he had progressive growth retardation, as you can see on the skin, and also a painful hepatomegaly. And on the biology, he had leukopenia. He had signs of hepatitis with AZAT and ALAT 3 to 4 times the normal level. He had thrombocytopenia, no inflammation or normal CRP, but a very high type 1 interferon signatures, an increase of CD8 T cells, and especially memory T cells. And these T cells were activated with a HLA-DR marker. He also had mixed proteinuria. Because of the fatigue and the decreased school performance, we thought that this child had a chronic antivirus infection. So we did CSF MRI, cerebral MRI, and CSF examination that came back normal, with normal interferon type 1 activity in the CSF. And because of the enlarged liver and because of the increased liver enzymes, we decided to go to the liver and try to find the virus, because we were convinced that this child was suffering from chronic infection. The liver biopsy shown inflammation with a intense infiltration of CD3 and CD8 T cells in the lobular space of the liver, and quite severe nodular regenerative hyperplasia that you can see on these pictures with these very nice nodulation of the hepatic parenchyma. He also had signs of fibrosis and also signs of portal hypertension. So quite involved, quite severe involvement in the liver. And because we were convinced this patient was suffering from a chronic viral infection, we did metagenomic NGS, which allows to identify unsupervised in an unsupervised way microorganism. We did it on the liver biopsy, and we were able to find sequences of IK virus. So this IK virus was quite new at that time. We were in 2020 in the middle of the pandemic. IK virus, as I said in the introduction, belongs to the family of picorna viruses as enterovirus. It's a non-enveloped virus with a RNA single strain sequence, first described in Japan in 1989 after an epidemic of gastroenteritis in humans who have eaten oysters. It's usually responsible for mild gastroenteritis in immunocompetent human, with a very high seroprevalence in children and in adults. So probably the virus circulates in the population worldwide, because it was these seroprevalence studies were performed in different parts of the world. And when we identified these IK virus sequences, Isabel Metz and her group just published one case of XLA patient with a chronic lymphoproliferation, hepatitis, nephromegaly, and IK virus sequence found in different place and organs of this child. So we thought that this could be the cause of the infection in this patient, and we identified the IK sequence not only in the liver biopsy but also in the plasma and in the urine of this child, not in the stools and not in the CSF. Because of the proteinuria, and because of the case report of Isabel, we were also interested by the kidney, and in fact, we identify enlarged kidneys in this patient. We tried high-dose immunoglobulin, steroids, ruxolitinib, because he was presenting a very high type 1 interferon signatures, and none of these treatments were really efficient. And because of his condition, because of the very chronic nature of this infection, the absence of improvement with the different treatment we used or which we tried, we decided to move to transplantation. And this patient received two haploidentical transplantation, one from the father, then the second one from the mother. He rejected the first transplantation condition with a trio through thiotepa and compact conditioning regimen. It was in aplasia, so we did as quickly as possible the second transplant. And after the second transplantation, we observed full engraftment, good T-cell reconstitution, quite quick B-cell recovery with an increase of the B-cell numbers 1 month and a half after transplantation. And the most interesting things is that after a few months and now for more than 3 years, we completely normalized the liver enzymes. We observed an improvement of the fibrosis by FibroScan performed in this child. And while we were identifying the IK virus several times before transplantation in plasma, in black, in urine, in yellow, in spleen samples, or in liver biopsy, we were not able to identify any positive samples after transplantation, showing that we normalize the liver enzyme, and in parallel we get rid of the virus. And we are now 4 years post transplantation. The child is doing very, very well. He's off immunoglobulin. He grew very, very well. and is doing very, very well. So we think that we have cured this patient with the bone marrow transplantation. Since this first observation, we had 8 additional observations, ending up with a total of 9 patients with chronic infection, mostly male, which is related to the nature of the underlying immunodeficiency. There were 3 patients with XLA, including the patient I presented, 3 patients with B cell deficiency after transplantation for severe combined immunodeficiency. These were 2 gamma C SCID and 1 Artemis SCID, who presented, who were transplanted with a mismatch family donor without chemotherapy, so ending up with a good T cells engraftment, but no B cell reconstitution, and they were all on immunoglobulin replacement therapy. There were 2 patients with combined immune deficiency, 1 ICF and 1 GINS1 deficiency, and 1 CVID patient. The beginning of the problems were occurred at the median age of 9 years, the range of 5 to 40 years, and the age of diagnosis of the IK infection was 16 years, with a 7 years delay between the onset and the diagnosis of the chronic viral infection. So quite a long term, showing that it's really a chronic disease. The first symptoms were usually liver enzymes increase, sometimes gastrointestinal problems, sometimes a fever. And if we look to the clinical course of this patient, as I said, it's really a chronic disease. All 9 patients had chronic hepatitis. 6 of the 9 had some renal abnormalities, with nephromegaly and or renal insufficiency. All the patients with a spleen in place had the splenomegaly. All patients with who started the disease in the pediatric age had the growth failure. Of course, the adults did not show growth failure, and most of the patients had thrombocytopenia that could be related to the portal hypertension, but might also be related to the virus itself. It's hard to decipher between the 2 causes of thrombopenia. This is just a nice picture from another XLA patient with enlarged kidney, as you can see here on PET scan, with not only big kidney, but also high metabolism in the organs. And this patient has indeed renal insufficiency with a progressive increase of the creatinine. We did some immunology in this patient, and we screened them with the CyTOF. And with these tools, we were able to identify very activated memory CD8 T cells population representing all of the IK infected patients, while this population was not found in match PID control. And these population of CD8 expressing high level of CD38 and low level of CD127, which is the receptor for the IL-7 receptor, was previously described in chronic infected patient, like a patient with HIV or a patient with hepatitis C chronic infection. We also did some single cell RNA sequencing in this patient, and we found very high signatures, interferon type 1 and type 2 signatures, mainly in CD8 T cells. So all findings compatible with a chronic viral infection. If we focus on the histopathologic findings in these patients with chronic IK virus infection, I already shown you some pictures of the liver showing high CD8 T cells and especially CD8 T cells infiltration with the granzyme B expression. All patients who had the liver biopsy had also nodular regenerative hyperplasia pictures. And when clonality was performed in the liver and in the blood, it was usually oligoclonal with the same profile in the organ and in the blood. Regarding the kidney, when the kidney was biopsy, we found a destructive kidney infiltration with tubulitis, also CD8 T cells infiltration, and some in some cases forming macrophages in tubular lumen of the glomerulus. So again, the CD8 is increased in the blood, but it's also increased in the inflamed organ. What are the best tools to identify these IK virus infection? The gold standard in our hands was the RT-PCR or the metagenomic NGS on frozen biopsies. We were not very successful on fixed biopsies, maybe because the viral load that we found were quite low, with a CT range between 32 and 42. So it's indeed a low viral load that we identify in these biopsies. The stools was not the best liquid to screen. Only one of our patients had the positive screening in the stools, and in the plasma and the urine, when there was kidney involvement, we found that 50% of the samples were positive for patients with a chronic infection identified in the infiltrated organs. So it means that when you think that you might have IK virus infection and you don't have a biopsy to search the virus, you really need to repeat the peripheral samples, plasma and urine, to try to identify these sequence of virus. Is IK virus really causative of this chronic condition? I'm pretty convinced, because we found the virus in the affected patient, but not in control PID, without hepatitis, without kidney problems. And we have screened a lot of these PID patients now. We were able to identify the sequence of the viruses by in situ hybridation in spleen and liver of two patients, and we were able to find the virus in the hepatocytes on this picture, and we were able to clear the virus and cure the disease by restoring B-cell immunity in some of these patients. And nowadays, 4 of these patients receive transplantation or gene therapy. And we observed a clearance of the virus in parallel to the normalization of the liver enzymes and the disappearance of the PCR in the blood. And in 2 patients, we also perform liver biopsies for clinical purposes, and we were able to show the absence of IK virus in these 2 cases. So we clearly found a concomitance between disappearance of the virus and clinical improvement. Since we are interested in these chronic viral infection, 4 cases has been described in the literature. The first case is described by Isabel that I mentioned, and 3 other cases. All cases were described in antibody deficient patient related to XLA or antibody deficiency related to anti-B cell treatment. All patients had hepatitis and renal involvement, and 3 of them were cured by B cell restoration, by natural B cell restoration after rituximab in 1 patient and after bone marrow transplantation in 2 XLA patients. So IT virus can be seen as an emerging pathogen in antibody deficient patient with chronic condition, responsible for chronic hepatopathy reminiscent of the chronic hepatopathy we observed in antibody deficient patient and CVID. Renal disease is also a concern in a subgroup of patients, and in all cases we observed an intense CD8 T cells infiltration in the affected organs. I will skip this norovirus because maybe David will mention this virus in the discussion, because he's really the big leader in the field of norovirus, but it's also another enteric virus that is a concern in primary immune deficiency, not really in B cell deficient patient, but more in T cell deficient patient. This drives me to the end. A few words about the immunity against these enteric viruses. What do we know about these, the immune response to control the enteric viruses? First of all, this is not easy to study the immunity against enteric viruses in humans, because to study the local immune response, we need gut biopsies, and it's not so easy to have access to these biopsies. We have some insights from vaccination and development of poliovirus vaccination and rotavirus vaccination. The very first event is probably early recognition of the viruses by the innate immune cells in the lamina propria of the small intestine, with presentation of the antigens by the DC in the local lymph nodes that present the antigen to the adaptive immune cells, and that allow the development of virus-specific T cells that can migrate to the intestinal tissues. The B cells of the Peyer's patches are also highly activated, undergo IgA class switching, produce a high level of secretory IgA that are able to neutralize the virus in the lumen and the lamina propria. So these IgA are thought to be really the major goal and the major players in this immunity against the enteric viruses, at least for the enterovirus and maybe for the IK virus, but we absolutely don't know. So we can also learn a bit about the immunity against these enteric viruses from the study of immunodeficiencies. If we look to the susceptible patient to the enterovirus and IK virus, these are mostly a patient with antibody deficiency, agammaglobulinemia, CVID, or a patient with a B cell defect after bone marrow transplantation for CV combined immunodeficiency. So probably B cell function are major players in the immunity against these 2 enteric viruses, while for norovirus and sapovirus and probably astrovirus, the role of T cell is probably significantly important, and even more important for adenovirus, that is a leading cause of problems, but mostly in patients with severe T cell immunity compromise, like a recipient of bone marrow transplantation, or a CV combined immunodeficiency or combined immunodeficiency. So that leads me to the conclusion. Enteric viruses, as you know, are numerous, and they are worldwide distributed. They are responsible for acute gastroenteritis, but not only. We know that antibody production is really important for some of these viruses, for sure for enteroviruses and for IK virus, while T cell is probably as much important for other as a norovirus. We have no new tools to identify these emerging viral agents like NGS that was shown to be very effective in our hands. So I think it's very important tools for primary immunodeficient patient. Of course, when you find a new virus or not very well virus agent in a patient, you have to prove the pathogenicity, and it's not so, it's a tricky point. And as you know, this chronic infection may underlie some immune dysregulation manifestation that are frequent in bone errors of immunity patient. And I think the rubella is another very nice examples of immune dysregulation manifestation associated with chronic viral infection. And with this, I would like to thank my team, especially Quentin Hiller and Muriel Schmutz and the microbiologist Jacques Forgeot, who are exploring these patients with me. I'd like to thank my colleagues in the immunology and transplantation unit, and I would like to thank you for your attention today.
Fantastic. Thanks so much, Benedict. There's a little bit of feedback there. That's better. That was excellent, right? And as I anticipated, again, I really enjoyed that one. Now, I want to kick things off because there is a risk here of opening what we'd say in England is a can of worms, because, and not necessarily the wrong can of worms. When I look at your description of the patients, they say that most of the patients with what you call IQ virus and I call HE virus have hepatitis, which is often a low-grade hepatitis with nodular regenerative hyperplasia on the biopsy. They've got a big spleen and low platelets. Right now, a lot of our CVID patients would meet that definition. Right, so. Now, they don't necessarily have the kidney involvement. And so I guess one question is, how significant do you think that is? But do you think that in all of these people, and there's quite a lot, and we don't really know what to do with them, so in many ways this would be a positive development, but all of these CVID patients with NRH, big spleens, low platelets, etc., should we be looking for viruses?
Sorry, David, but my microphone is crap, and I didn't understand a word of what you said. So I'm very sorry. I'm changing the computer while you maybe ask questions or answer some questions. I'll be back in 2 minutes.
Okay, thank you very much. All right. Well, in that case, we can have a look at in the Q&A, and actually there's another question for you, Kate, if you're still here. Yeah. There we are, which is about the presence in granulomas of the other viruses in the vaccine, in the MMR vaccine. So have you found chronic measles or chronic mumps?
We have not, and we have looked among patients that are missing or have mutated interferon receptor. As you know, the measles component can cause a really terrible encephalitis, but we have not found measles or mumps in the granulomas.
Excellent. Thank you very much. And one other point that I would make while Benedict is changing her hardware, in relation to enteroviruses, is she touched on polio. And of course, we know that people with inborn errors of immunity, predominantly combined immune deficiencies, but potentially people with isolated antibody deficiency can excrete vaccine-derived polio if they're administered the live vaccine indefinitely. And there's now a new campaign in certain countries, but probably most importantly Pakistan, where if you've been in Pakistan for more than 4 weeks, then if you can't demonstrate that you've been vaccinated, they will give you the oral, as in the live polio vaccine, as you're leaving the country. So they just give it to you in the airport. And so it's just something to be aware of with our patients, because of course they or their relatives may well start to be exposed to the live polio vaccine via that route. And we might start to see cases. And you may be aware that we've seen a little outbreak in London recently where that happened. We had a little bit of probably circulation within the community for a few weeks and starting to get mutations within the vaccine-derived polio. Fortunately, no actual cases of clinical polio, flaccid myelitis, but that is something to be aware of. Benedict, how are you? Oh, she's disappeared. How are you doing?
Yeah, I'm back, and I'm very sorry about that.
No, that's great. Can you hear me?
And I have to say, I didn't really answer your questions, but actually I didn't understand anything because my microphone was trapped. So may I ask you to repeat?
That's okay. Can you hear me okay now?
Yes, it's perfect.
Okay. So the question was that when your description of the patients with chronic, as I say, you'd say IQ virus and I say HE virus, but the virus.
This is my French accent.
Well, and it's probably my English accent, right? So, so you described them as having a low-level hepatitis with nodular regenerative hyperplasia on the biopsy, big spleen, low platelets, all right? And then often the renal involvement. And one question was, how important do you think the renal involvement is? Because otherwise, if we just applied that definition, then there's a lot of CVID patients, a lot of CVID adults who would fit that definition. And the question is, should we be looking for viruses in all of those people? Maybe we should, right? As Kate said, we weren't expecting to find rubella in the skin granulomas. We probably weren't expecting to find norovirus in CVID enteropathy, 15 years ago. So I guess that's a question, but there's a lot of people we then would need to be looking for viruses in their biopsies.
I think if you have a typical picture of a patient with a chronic hepatopathy and chronic renal involvement and enlarged kidney, you definitely have to search for IQ virus. And if you don't find it on the first samples, you have to repeat the samples, because I'm really convinced that this association of kidney and hepatopathy is very typical of these chronic infections. The problem is to identify these viruses, because as I mentioned, the viral load is low. It's an RNA virus, so it can be a bit tricky if the sample is traveling, if the traveling is cold or hot or whatever. So repeat samples. It's usually highly infiltrated of CD8 T cells, and all patients with CVID and nodular regenerative hyperplasia, they don't all have this high level of CD8 T cells infiltration. So if you have a very low level of CD8 infiltration and no renal involvement, maybe you can search for virus, but you might not find IQ virus. As you know, we also have patients with a chronic norovirus infection and a very similar picture, at least in the liver, not in the kidney. But we identified chronic norovirus infection in patients with chronic hepatopathy in different antibody deficient patients. So we think that there might be a link between these chronic enterovirus infection and hepatopathy, not only with IT, maybe with also with other enteroviruses. It might be a different physiopathology. Actually, we don't know everything about this condition, and it's really a field of intense research, and we are part, of course, of these efforts.
Yeah, and I agree. My theory has often been that that it's impaired gut barrier function. So it's not necessarily a sort of direct infection of the liver with something like norovirus, but that impaired gut barrier function is the initial insult. And then translocation of a lot of largely bacterial products that then lead to the liver damage.
I fully agree with what you say. It's a problem probably of the permeability of the gut barrier, but IK virus is found in the liver.
Right. Agreed. Exactly. So back to my.
Why I said it might be a bit different between norovirus and other enteric viruses and IK virus, because the virus is found in the liver.
Yeah, I completely agree with that. So I think to summarize the initial part of the question, if you've got someone with a significant inflammation on their liver biopsy, and especially a sort of CD8 T cell infiltrate, it's really worth looking for a virus. And arguably it's worth looking even in the people who've actually even in everyone with NRH, if you look hard enough, they almost always have at least low-grade inflammation. So, the question, so should we be looking in everyone? Well, I think if you can, why not?
Yeah, if you have the tools, I think, of course, you have
absolutely.
You will probably not win in all cases, but you may win in some cases. And I think if you have the tools, if you have the frozen biopsy, of course, you have to do NGS and specific PCR for all these viruses.
And as you said, and if big kidneys as well, that's really subjective. Yes. And okay. Okay, we've got some questions in the Q&A. So Gisela Seminario, who asked this question earlier, and we saved it for you, Benedict. It's about two brothers with XLA, the youngest with chronic hepatitis, NRH, and HHV8 infection. The oldest has stool enterovirus and now has chronic hepatitis and waiting for hepatic biopsy. What is your opinion about bone marrow transplant and XLA with chronic viral infections? So once I don't know how old they are, but anyway, let's put that to one side, assume they're fairly young. So what do you think?
This is maybe a question where Kate may have an opinion also. I think chronic viral infection in XLA are really concerning. And restoring B cell function is the cure for these patients. If you have tried high dose immunoglobulin, if you have tried some antiviral or nitazoxanide and you are not successful, I think the best is going to transplantation, not too late before organ damage. So if the liver is still okay, if you don't have signs of serious portal hypertension, you may think of going to transplantation. I'm not comfortable with the HHV8 because it's not an usual agent in this patient, and so I'm not fully confident with this case. But in a general concern, chronic viral infection in XLA patient not responding to the usual treatment we can give to this patient should drive the patient to transplantation.
Great. Yeah, I would agree with that. Kate, anything you want to add to that?
No, we're pretty poor. Sorry, I said that completely backwards. We're very pro-transplant. So we would probably offer it to those kids. I don't know that that's the right decision, though. And we've recently offered transplant to some boys with XLA with enterovirus, and the families have turned us down, hoping that gene therapy becomes a reality. But boy, there's only a finite number of brain cells. I don't know what the right answer is. So I never push people, but I try and offer a range of options.
Great, thank you. And then related to that, Vanessa asked about whether we've seen exacerbations of the viral infection during conditioning.
Have not. It really is like HPV. It just sort of vanishes.
We did not observe the deterioration between during the conditioning and during the first week after transplantation. I think it's a chronic infection, so of course, you increase the immunodeficiency of the patient during the process, but because it's chronic, probably you don't damage too much the patient with this process.
Yeah, and I guess coming back to Kate's model of, you know, how much is host and how much is the pathogen, and actually in a lot of these diseases, we've said, you know, they're somewhere in the middle, and your conditioning is probably going to help the host side, right, in terms of turning off inflammation. So yeah, it's a sort of double-edged sword, I suppose, there. There's a related question as well, whether in the first case, Benedict, whether the active viral infection might have played a role in rejecting the first transplant. Do you think that might have been, was it cause or effect?
Yeah, the patient with the IT virus, he had the highest type 1 interferon signatures I've never seen in a patient. So I think this inflammation played a role in the rejection for sure.
Yeah, I have a patient with chronic SARS-CoV-2, and I know we're not talking respiratory viruses really today, but it has something very similar actually as well. So, yeah. Okay, and then some questions about immunoglobulin. So, do you think that insufficient IgG trough increases the chance of development of things like enteroviral encephalitis? I mean, there is always this, you know, idea that you should keep your XLAs with a much higher IgG trough for a variety of reasons, but perhaps one is in preventing things like enterovirus.
It's a good question. I think for sure, immunoglobulin replacement is efficient to prevent the infection, but not completely efficient, because 10 to 15% of the XLA patient will at some times develop the chronic enteroviral infection. When the infection is there, the benefits of the immunoglobulin, the high dose immunoglobulin, I think depends on the frequency of the virus, the circulation of the virus in the population, and the probability of finding a good level of efficient immunoglobulin in the preparation. We had success of high dose immunoglobulin with enterovirus in XLA patient, but we also had a failure, like we are no experiencing with this CARICOM data.
Yeah, no, absolutely, and I guess we've had similar experiences. I mean, it's easy to give it, you know, in terms of treatment, but you know how effective it's been is pretty variable.
Yeah,
but
when you decrease the dose of immunoglobulin and you go back to normal substitution, sometimes you have a re-increase of the infection.
Yeah, absolutely. Another question, and someone asked about intrathecal immunoglobulin. Have you tried it?
Yes, we tried in some patients. This is risky, I think, because you need a Ommaya reservoir, and you have to go. You have to repeat the injection. I think if you have to do that because the high dose immunoglobulin don't work, you probably have to consider transplantation, I think, or gene therapy maybe one day. But
yes, well, we all hope so. A couple of final questions. There's some that are also in the chat as well. A couple of people have asked about lungs and whether you've ever found HE virus in lungs.
Not in my hands, but why not?
Yeah, there's a patient at the moment in the UK who may well do. You know, looks suggestive. So certainly, you know, has it in liver and looks like probably has some pulmonary involvement. Yeah. There's a question here for you, Kate, about whether the eye could be a reservoir for virus, considering ocular immune privilege. Our local ophthalmologists have recently found rubella in a couple of adult patients with unspecific eye disease.
So there isn't, so Jenny, clearly very astute question. There is this eye disease that's been described for about 10 years called Fuchs heterochromatic iritis, I think. And the classic feature is your one eye changes color and you find rubella virus and you find rubella IgG. So clearly the eyes can harbor rubella long-term. It is a chronic process. It doesn't much damage the eye. It just changes the color. So it's sort of an innocuous, persistent virus in that setting. I hadn't honestly considered it as a reservoir for the cutaneous lesions and the solid organ granulomas. I think that's a great point.
Yeah, really interesting. Yeah, and it is clearly an immune privileged site, right? Okay, and then I think we're going to have to wrap up in a couple of minutes. So there's a final question, which I'll just broaden out a little bit, which is about fluoxetine for enteroviral encephalitis, which is an intriguing one, which we've used a little bit. And I suppose, to broaden that out, you mentioned some treatments in your talk, Benedict, but again, any other novel antivirals, etc., that you would think about for enterovirus, and I suppose EQ virus as a related.
I didn't mention the fluoxetine in my talk. We tried. We had toxicity. We stopped, and we had no benefit. I don't know.
Yeah, I mean, clearly there's some case reports of at least partial success. We've had someone treated for quite a long time with fluoxetine as part of the mix, who seems to be heading in the right direction, but that's a mix with, she had pacapavir, she's also on favipiravir and nitazoxanide. So, it's difficult, and lots of IVIG, so it's hard to know what's doing the work if she is getting better. But we figured that, as you said, Kate, there's a limited number of brain cells, and so we're quite aggressive with our management, in these chronic cases. Isabel, by the way, answered the question about they found AIK in the sputum of their first patient and bowel. So there we go. So there's at least 2. Okay, fantastic. Okay, I think that's probably about all we've got time for. Thank you both. That's been absolutely fascinating. As I say, with my bias, I'm always going to find a session like this really fascinating, but I've really enjoyed it. I hope that everyone who's still here, there's 160 people still hanging on, and I hope that you've all enjoyed it as well. If you've got any follow-up questions, please feel free to get in touch with any of us. I know there's going to be an ESID Juniors session with case presentations on this theme in the near future as well. So thank you all very much, and enjoy your evenings or mornings, depending on where you are in the world. Thanks. Bye-bye.
Thank you very much to everyone. And thank you, David, for organizing this very great session.